So, good morning, everyone who live in Thailand, or good afternoon or good evening if you are living in other part of the world. So, welcome to the Asia EHealth Information Network site meeting of the Prince Mahidol Awards Conference 2022. Our topic this morning is Digital Health for Universal Health Coverage. My name is Priya Saishon and I will be your moderator for this session. So we have divided this session into two parts. The first part, we cover the Mind Gaps framework of AeHIN, and the second, we delve into the interoperability work of AeHIN in general, and of that in Thailand in particular. Because we have a full morning, so actually, our speakers come from Thailand, Philippines, Malaysia, India, and the United States. So you will learn more about them as they introduce themselves when they start the parts. To save time, I would like to introduce Dr. Bunchai Kisanayotin, Chair of the Asia eHealth Information Network, to give his welcome remarks.
Thank you, Piraya. Hello, everyone. Good morning, good afternoon, good evening for our friends across the globe. I am Bunchai Kisanayotin. On behalf of the over 1,400 members of the Asia eHealth Information Network, I would like to welcome you to this session on the digital health for universal healthcare and primary care. Before I forget, I would like to extend my gratitude to the organizer of the Prince Mahidol Award Conference 2022 for allowing us to present our Mind and Fill the Gaps frameworks. We salute the long tradition of the Prince Mahidol Award Conference supporting universal health coverage and thank them for recognizing AeHIN's contribution to advancing digital technology to support it in Asia Pacific country and the world. I would like to introduce our first speaker, Dr. Alvin Marcelo from University of Philippines to introduce our networks and also present our GAPS frameworks. And he is a champion on the governance at the Philippines. Over to you, Dr. Alvin Marcelo.
Thank you, Dr. Bunchai. Thank you, Lukwa. Thank you to the organizers of the Prince Mahidol Awards Conference. We are honored to have a side meeting again in the PMAC. So who are we? The Asia eHealth Information Network is a network of digital health advocates from government, academe, non-government organizations, and the private sector. We started with 7 people from 6 countries. It is a collaboration of digital health advocates created by the World Health Organization in 2011 to help Asian countries with their digital health development. Now we are more than 1,000 members, over 20 countries. Our structure is that we have the network or the General Assembly at the top. They are the ones that we serve. We have a small group called the Working Council members, which are volunteer representatives from the countries. Many of them are from the Ministries of Health. Then we have the Governing Committee, who I will introduce in the next slide. And then over the past 10 years, we have created committees like the REACH, the COIL, and I will explain those organizations and subcommittees later on. You've heard from our chair, Dr. Bunchai Kisanayotin. He is our chair. I am the executive director, and our board members are Dr. Fazila Alauddin from Ministry of Health and Mr. Jai Ganesh, and they will have their own presentations later on the respective parts of the GAPS framework. So we all started in 2011 in a conference in Hoi An, Vietnam on health information systems interoperability. Over the past 3 days of those events, we all agreed that we all needed and wanted interoperability, but it was not yet possible for us. And so 3 months later, we met again under the auspices of WHO and ADB. And then we were again talking about the problems that we already discussed in Hoi An, Vietnam. And so we thought, why don't we share the solutions that each of us have developed and create a learning network? And this is where the 7 people from 6 countries seeded the Asia eHealth Information Network. By 2011, December, with support for the World Health Organization, we conducted our first strategic planning for AeHIN. And we said we should do these 4 things: encourage leadership and governance for eHealth, build capacity for eHealth, civil registration, and vital statistics and health information systems, exchange knowledge and share expert resources, and promote standards for interoperability. So our first offering was training on HL7 because we thought we needed standards and interoperability. By 2012, in Bangkok, Thailand, we had our first general meeting. The next year, in 2013, we had our second AeHIN general meeting in Manila, Philippines. And here, our key takeaway was we needed to model good governance. And this is where we formed the AeHIN Working Council members. Also, around this time, we realized that the people who underwent the standards training in HL7 also needed support on enterprise architecture or blueprinting. And so we again started to seek out training on enterprise architecture or TOGAF. This is our picture in that second general meeting in Pan Pacific Hotel, Manila. The third meeting of the general meeting was in the Asian Development Bank, who hosted the venue in 2014. And at this time, we already had some people who had undergone enterprise architecture training, and they gave us feedback that, this enterprise architecture work is official work and it's very hard work. So we need to have governance that supports the enterprise architecture activity. And this is where we identified that we needed to have capacity for IT governance or COVID-5. Our picture at the Asian Development Bank conference. By 2015, we had our conference in Bali. And this is where we identified that, interoperability is a very hard concept. It requires a lot of coordination from different people. It requires technology, software, and hardware. So why don't we get training as well on project management? And this is where the concept of the Interoperability Lab was born. And that's our picture in Bali. Very nice place. 2 years later, we had our 5th AeHIN General Meeting in Naypyidaw, Myanmar. And this is where we first officially heard from a Minister of Health from Myanmar talk about the importance of minding the gaps. And this is going to be the set of slides that we will present later on, what we mean by GAPNS. Our picture in Naypyidaw, Myanmar. Our 6th AeHIN General Meeting was in 2018, Colombo, Sri Lanka. And the summary here is that we started to invite people who are interested, or countries who are interested in interoperability, and we asked them, are you willing to form a community of Interoperability Labs, or COIL? Because at that point, the Asian Development Bank had supported the creation of an exemplar Interoperability Lab called the Standards and Interoperability Lab Asia as the first template lab to be replicated across all the country labs. And we'll have in this part 2, we will have a more detailed presentation of the community of Interoperability Labs, and later on, Professor Philip will present the Standards and Interoperability Lab Asia. Our picture in Colombo. In 2021, we had a pandemic, but we proceeded with our 7th AeHIN General Meeting. And this is where we realized we needed to strengthen our enterprise architects. We had people who were trained in enterprise architecture, but they were not really being designated as official enterprise architects of their ministries of health. And then we also knew that the community of Interoperability Labs, they needed to be trained by the Standards and Interoperability Lab Asia. And we had some labs like Thailand who were trained by the SILA. So over the 10 years, we have summarized the work that needs to be done as what we call mind the gaps and fill the gaps. Mind is looking at your governance, your architecture, your people and program management, your standards and interoperability. Governance is the leadership. Architecture is the blueprint with the mandate of the leadership. People and program management are the people and the companies and the organizations that will follow what's on the blueprint. And standards and interoperability are the building blocks inside the blueprint. So we hope that with the mind the gaps and fill the gaps, the member countries of AeHIN would be able to systematically create a national digital health program because they followed the GAPS framework. And so now I will now go in detail on the G part of the Mind the Gaps framework, which is governance. And for this part, we basically summarized our call to governments and stakeholders to support the leadership of the Ministry of Health in developing national digital health strategies that respond to the needs of universal health coverage, such as registration, prevention of diseases, treatment, rehabilitation. And as the health sector leader, the Ministry of Health, in turn, will ensure that there is coordination and collaboration of digital health projects of partners and stakeholders in the country and also of the international development partners. This is very important because as we have seen in the past 10 years, digital health is very complex. It cannot be done by the Ministry of Health alone. They need the support of the Ministry of ICT, the Ministry of CRVS, Economic Development, Home Affairs. So to be able to do that, we need to have good coordination of the multi-sector. So our call for governance is a multi-sector coordination mechanism. Let me explain more about that in the next slide. So health systems are very complex. This is the US health system. As you can see, these are just, each circle is a stakeholder in the US health system. I will not be surprised if all of the other Asian countries will also have a very complex structural system. The reason is in any health system or health sector, there are many stakeholders. There's the hospital, the clinics, the doctors, the nurses, the pharmacies, and then each of these stakeholders will have their own specific transactions and with each other, and all of them will have different rules and contractual arrangements. Next slide. So we have the health sector. Next slide, please. You have the health sector, the finance sector, the insurance, information technology, science and technology, privacy and protection, economic development, and workforce, and to name a few. It's a very complex health system environment. Next slide. So in AeHIN, we have realized that universal health coverage requires the coordination of these stakeholders. They need to work together. They can compete perhaps, but they also need to collaborate and coordinate the work that they do. And we think digital health is the one that will enable this coordination of the stakeholders. Unless we give them a platform for digital health, they will always be complex. We will never be able to understand what are these transactions and relationships that they have with each other. And third, this digital health is not easy to build. We need good governance to ensure that there is digital health that enables this coordination. And that's why we think governance is the first key important task of all governments to do. They need to bring all the stakeholders together so that they can have a coordinated way of moving forward. So how do we then navigate this very complex health system? And also, what do we mean by govern? Thankfully, the World Health Organization and the International Telecommunications Union, which is the UN agency for ICT, came up with this National eHealth Strategy Toolkit way back in 2012. And this has become a reference for AeHIN. Let's look at what's inside the National eHealth Strategy Toolkit. It proposes 7 components in a national eHealth strategy. They were still calling it eHealth back then in 2012. At the top, you can see all-encompassing from left to right is leadership and governance. And underneath are strategy, investment, legislation, policy, and compliance, and workforce. And you can see the 3 layers: infrastructure at the bottom, standards and interoperability that should run on top of that infrastructure, and then services and applications that should use the standards and interoperability that are running on top of that infrastructure. That is actually a blueprint. The WHO and ITU is telling us a proper way to approach a national eHealth strategy. Now, let's dissect leadership and governance. According to the WHO ITU, leadership and governance in digital health or eHealth is led by the health sector. But there is a steering committee that supports the health sector, And this steering committee is supported by a core EHealth strategy project team who does all of the hard work, because the steering committee just makes decisions and approvals. And on the left side are the stakeholder reference and experts that should be advising the steering committee. And on the right is the public or broader stakeholder who are the beneficiaries of a well-coordinated digital health system that supports the universal health coverage. So this is the proposed template of leadership and governance of the WHO and ITU. So now let's see. In 2012, when the National EHealth Strategy Toolkit was released in the Philippines, and I was a participant of this process, we adopted the WHO ITU National EHealth Strategy Toolkit, and the Minister of Health said, okay, let's follow the framework. Let's invite the Minister of ICT, the Minister of Science and Technology. Let's invite the National Health Insurance Corporation, the Philippine Health Insurance Corporation. Let's invite the National Health Sciences University, which is the University of the Philippines, Manila. And because I was teaching there, I was involved in that process. So together, they formed the National EHealth Governance Steering Committee. But they were very busy people. You know, the ministers are very busy people. So they identified their second in commands. And together, the second in commands, they formed the National EHealth Governance Technical Working Group. So these are directors and vice ministers. And together, because they are also busy, they formed the National EHealth Program Management Office. These are very young people with project management responsibilities, day-to-day operations. Their role is to document what is happening, to remind the technical working group on what is on the agenda, and to make sure that in between the meetings, all of the commitments of the different sectors, health, ICT, finance, academia, are actually moving forward. And this is what I mean by coordination, because digital health is very complex, many players doing different things. And unless they are coordinated and there is somebody coordinating their work, their projects might actually fail because the projects of the other sectors are not actually available. So this coordination is very important. Now, on the left, you see are the committees or stakeholder expert groups that we form. There's the data standards expert group, the data security and privacy expert group. The advisors group are private organizations that we consult. And the capacity building task force are those in charge of the training of the workforce. And the EMR committee are composed of the first few electronic medical records that were actually running in the frontline clinics of government. On the right side are special organization or committees between the Department of Health and PhilHealth, specially created to make sure that the interfaces and the application programming interfaces are coordinated between DUH and PhilHealth. And on the right lower portion, you can see this is very, very similar to the recommended structure of the WHO ITU National EHealth Strategy Toolkit. But the Philippines added the National EHealth Program Management Office. And I think that is our contribution to the knowledge base, that without the National EHealth Program Management Office, it's very hard for digital health and eHealth to move forward because there's no one taking care of the detailed coordination within the Ministry of Health and across the other ministries, because they also have other projects in the Ministry of ICT, in PhilHealth, and in UP Manila. And so this is the priorities that were set by the steering committee. As you can see, it is similar on the right lower corner. It is similar to the components of the National EHealth Strategy Toolkit. And this is now our architecture on the left side. So the Health Information Exchange, which was designed and approved by the National EHealth Steering Committee, as you can see on the right, it patterns after the OpenHIE Interoperability Framework. And we are honored to have Professor Paul Biandi later on, the leader of OpenHIE, to tell us more about OpenHIE and what are their plans for Asia and for the global community. And so I'd like to summarize governance as follows. For AeHIN, governance means, first, creating a multi-sector coordination structure led by the health sector. And this is what is recommended by the WHO and ITU. It's multi-sectoral because although health is the reason the Ministry of Health cannot do everything about digital health. They do not control the telecommunication system. They do not control the reimbursement system for health insurance. They do not control the capacity building that are happening in the university. So this multi-sector coordination is very important. This is where everything starts. And what do? The first thing that they do is they set priorities. And usually these organizations in the multi-sector coordination, they have different priorities. But as long as they know what these different priorities are, they can see that if they work together and they succeed in their respective projects, then it will be a successful digital health system. How do we know that they are all working together? They should have a shared blueprint, number 3. And that blueprint shows what are the different projects of the different sectors and who is responsible for each of them. And number 4, we would like to confirm from the ministers that they are the owners of those specific key projects, like who is in charge of the national identification system, who is in charge of the interoperability layer, who is in charge of the benefits development of health insurance, etc. Number 5, we want to ask them, please invest. Please invest on your key projects, because if you do not invest on your key projects, your project will fail. And if your project fails, the whole digital health system will fail, because your project is an important component of the blueprint. And finally, we ask them to monitor the success of the projects and be accountable for the success. Because if the projects are successful, then we can have a better chance to build the unified digital health system for UHC. So in summary, governance means A, simply making sure that the needs of your sector are met, and B, simply just meeting together regularly across the ministers to coordinate your decisions and your projects. And this we request that be led by the MOH. And so that is the governance, and I'd like to pass the floor now to Dr. Fazila. If you have any more questions about governance, please feel free to type them into the chat box and we will address them later on. Thank you. Dr. Fazila?
Yes, thank you. Thank you, Alvin. Next, I'll be talking about architecture. As we know, many countries, in fact, globally, use digital technology has been really escalated during this pandemic. So I think it's very important that we must be very clear on the vision of digital transformation. Hence, architecture is very important. Architecture is actually a shared enterprise blueprint. As you know, the health system is very complex, as mentioned by Alvin earlier. And in this environment, a shared blueprint or a roadmap that all stakeholders can understand is very important. Hence, we at AeHIN will recommend designating an enterprise architect in the Ministry of Health to oversee this blueprint, engaging experienced professional and certified enterprise architects to advise government and development partners on the blueprint formulation. And also we can actually consolidate number 1 and number 2, and you can reach out to REACH, which is our regional enterprise architecture council for health, for knowledge sharing. Now let's look what is enterprise architecture. EA is actually a blueprint, and it's actually a coherent framework of principles, methods, and models used in the design and realization of the enterprise organizational, the structure, the business process, information systems, and digital health infrastructure. EA is also commonly described as the master plan, providing a holistic view of the entire enterprise as a system of systems. I took this, there are many definitions to EA, so this is one of the definition. But what's important is, why is EA important at the national level? It actually aligns business and technology strategy into a single initiative to achieve a common goal. And it delivers citizen-centric services cost-effectively and also strengthens cross-agency collaborations for information sharing, data mining and analysis, application and infrastructure consolidation and shared services. But what are the major challenges with EA in many countries? In fact, I think many countries are facing the same thing. We have lack of EA skills and competency, but my advice would be not everyone needs to be certified as an EA architect, but there must be one or two that is certified, and others must be exposed and have awareness and knowledge about EA. There's also a lack of EA knowledge and leadership among senior management. The word EA itself scares many people. So hence, some of the words we use is like blueprint or master plan is also it's advised to use for those who do not understand what EA is all about. And there's always a gray area between ICT and business. So we need really a driver to push EA. So I think creating champions of EA in your ministries is very important. And we really need clear understanding that ICT project is all about business transformation. It's not about ICT. I think that message must be clear to everyone. I'm sure, like how Alvin shared about what's happening in the Philippines in terms of governance. I'm just sharing EA of the Malaysia's public sector, which we call it as MyGov EA. I took this from our Mampu, our website. MyGov EA is created, actually established in 2015, and it was created for the Malaysian public sector agencies. And the public sector of EA shall be implemented, all public sector EA must be implemented by adopting this MyGov EA. If you really look into this framework, it is taken from TOGAF. So since 2019, all ministries who are implementing an ICT project above a certain million ringgit required to have an EA methodology and also BDAT. BDAT is actually business, data, technology, and application architecture. These are the four main architecture that is required under EA. And EA methodology is also used when we were developing our digitalization strategic plan for 2021-2025. In fact, all ministries have to have this methodology in their digitalization strategic plan, where you really have to align your business needs to ICT, and everyone has a common goal. Actually, it was difficult at the beginning. I'm not denying that. It was tough, but once you have started doing it, it actually resulted in better convergence and alignment of business and ICT strategies. So it's just good to start it, and it'll be easier after that. So these are some of the architectures we have done in the Ministry of Health. We have the organizational view, what is the service that's offered by Ministry of Health, who are the users, what are the external and internal agencies that's involved, what are the information that's required. If you see on the left top, we also have business architecture in terms of health information exchange for our virtual clinic. We also have the application architecture, technology architecture, for example, the cloud architecture, and also some of our application information usage view. So yes, like I've mentioned earlier, it's tough to do at the first time, but once it's done, and this is the reference document that can be used throughout, and everyone has the same goal and to achieve at the end of the projects. So this is actually one of the what I would say benefits of doing EA. So I hope this has given you some sort of a background, what is EA and how architecture is very important. So next, I think our gaps will be the P, which is for project, for people and program management. So I'll hand it over to Jai Ganesh, one of our senior leaders of AeHIN, to take this. Jai, to you, Jai.
Thank you, Fazila. Next in the gaps recipe from AeHIN is the people and program management. As you would have heard from Alvin and Dr. Fazila, like architecture basically gives you the bigger picture, but then there has to be a team that actually makes things work. So this is where the people and program management part of the gaps come in. Typically, like I don't need to, I think stress again or reiterate that national digital transformation in health is a complex subject, and there is a lack of capacity in the ministries of health to manage programs. Programs typically consist of multiple simultaneous digital health projects. So maybe people are good in managing their own projects, but then when there is a multitude of them, how to do it all together is something that people need to be prepared with. And this is where the program management comes and the program management office. And this typically requires multi-sectoral coordination. For example, somebody wants to say a national telemedicine program has to be implemented, then there is also connected to having the infrastructure and regulations in place. So that typically involves multiple ministries and multi-sectoral coordination. Usually consensus building takes time, but then the results are more sustainable. So this is something that we are professing for that. And then interoperability requires, like, since the topic today is interoperability, I'm also trying to relate to that. Interoperability requires close coordination of various projects, often led by multiple departments, even within the ministries of health. Forget about the other ministries. So effective program management ensures various stakeholders are there to synchronize their efforts with each other to achieve optimal impact. For example, standards, when adopted by all the stakeholders, naturally leads to interoperability. So there is a call for action for program management. AeHIN calls upon stakeholders to support the ministries of health, strengthen the capacity and the capability of the National Digital Health Program Management Team or the office. This includes developing capacity to manage multiple digital health related projects in partnership with other sectors, which is also very important. As it was stressed by the previous speakers, Ministry of Health cannot do the digital transformation in health alone. They have to work together with the other ministries. We encourage the Ministry of Health to establish a pool of certified project managers. And then AeHIN actually provided a training in Prince 2 in July 2019. There was a cohort of 30 people selected from ministries of health in various countries in Asia who were trained. And ministries of health, of course, can leverage the learning networks, just like AeHIN, to catalyze the knowledge exchange across countries in the region to facilitate peer learning, sharing, and support. So this is important, like to have a network like AeHIN in the region where we can trust each other and then share and support each other and also learn from each other's experience. So in short, like if I can summarize what is people and program management. So basically, it encourages cooperation among multiple sectors and multiple stakeholders that will enable the collaboration among them. And then there is a coordination mechanism which the program management team provides. And then we suggest that the countries to actually evolve a convergence mechanism. And then next topic will be the convergence workshop, which I will be briefly introducing. Once there is convergence among various sectors, various ideas, and with the overall blueprint in the background, then there will naturally be the coherence. Convergence workshop is something that we evolved after a lot of experience in our conferences, meeting with the ministries of health, and then in 2017, like we came up with this idea of suggesting to the ministries of health to actually lead convergence workshops. Basically, Convergence Workshop, the objective is to establish multi-sectoral coordination mechanism for the National Digital Health Mission with Ministry of Health as the lead agency. And then the output typically is all stakeholders can converge their efforts and support the National Digital Health Strategy. So there is a National Digital Health Strategy at the national level. Now there is also the WHO strategy for there is a global strategy for digital health released by WHO last year, and then how we can actually align to that. So this typically involves various steps, and ministries of health takes the help of regional digital health networks like AeHIN to actually facilitate the discussion and take this forward. We have roughly categorized under various steps. That is, there is a request and coordination, planning, preparation, implementation, and follow-up. Of course, external stakeholders are the development partners and UN agencies. And in short, the whole aim of Convergence Workshop is about people interoperability. while our aim is to have interoperability among fragmented health information systems, that is not possible without having people interoperability. People interoperability makes things easier, where projects can actually collaborate, cooperate, and coordinate to have the systems interoperability. I would like to give you an example from a recent uh, Convergence Workshop that AeHIN has facilitated in Lavapedia. Earlier last year, the picture that you see on the left-hand side is slightly ahead before the pandemic struck in. And then we had this Convergence Workshop being facilitated by AeHIN, supporting the Ministry of Health in Lavapedia to conduct this event, wherein AeHIN was able to actually put together an agenda where different partners, including development partners within the country and international development partners, came together and to support the Ministry of Health. And then GAPS framework was extensively used. So this is something that I would like to highlight for this Convergence Workshop. GAPS became at the base, where people were able to actually identify the gaps in terms of governance, architecture, program management, and of course, standards and interoperability. And then more recently, we had a follow-up session coinciding with the Digital Health Week program of Transform Health. This was in December, where the report of the Convergence Workshop that was conducted in March 2021 was presented, and from there, 7 priority areas were identified by the ministries in discussion with the development partners in AeHIN. So those 7 priority areas have been listed below. And then with respect to program management, because that was what I was to highlight, we found that there is no unit or there is no program management team within the Ministry of Health. This was identified as a high priority area, and then the TOR for the TA is being prepared. So that is in short my presentation about the program management and then the Digital Health Convergence Workshop, which AeHIN has been suggesting to the countries to conduct. And I would like to hand over to, because since the topic is interoperability, the focus is on interoperability, I would like to hand over the stage to Dr. Bunchai, who is our chair, as well as an interoperability expert himself, to talk about standards and interoperability part of the gaps. Thank you very much.
Thank you, Jai, for your presentation and the group. As Dr. Alvin Marcelo said, that the standard and interoperability is a very important component of the blueprint and architecture. And you know, what we learned over the past 10 years, that we first, that if we have the standard and interoperability, everything will solve. The hard lesson that we learned, that this is just part of the overall system, but it's very important. It is a foundation. And you know that we starting with using the thinking that if we have standard, then everyone will adopt. So we request the World Health Organization, Western Pacific, to train the people in this in our network on the HL7 standard. It come to nothing, and we realize over the year that the other component is also important too. But standard and interoperability is kind of the surface that you can see, because of the system is not working. That we in our GAP framework, standard and interoperability is one of that is the one of the component of this. And we request to for the standard and interoperability in the region. We think the open access and technical assistance to the international health standards like the ICD-10, NOMAD, HL7 FHIR, the health these health information standard crucial for the interoperability of the system, and it's part of the blueprint. It enables every health data to be shared, to be exchanged, and later in this morning session, you can see more in detail about the work related to the standard and interoperability in many countries. And today we will feature the standard and interoperability works in Thailand. In AeHIN, you see that the architecture, the blueprint is the one that we form the community of practice. We call the Regional Enterprise Architecture Council. We work together with the group who interested in the standard and interoperability. We form the Community of Interoperability Lab. We work with the other developing partner like the University of Philippines, the ADB, and then luckily with the support from the three, four party, we can establish we call the regional labs, support by the ADB and University of Philippines. That is the standard and interoperability lab, Kyla. So to give you more detail about the regional, and then we'll go down to the countries, which as Dr. Alvin said, that we learn from the template that the Kyla learned from the international communities to form the country interoperability lab. So our next speaker to give you the pictures of the Kyla is Professor Phillips Suninka from the University of Philippines. Over to you, Professor Phillips.
Thank you very much, Dr. Bunchai. So we are very happy to be part of this very prestigious conference. So as mentioned by Dr. Bunchai, so I am Phillips Suninka. So I'm the Technical Director of Kyla. So before we discuss understand interoperability, I think it would be good to summarize what Dr. Marcelo, Dr. Pasela, and Jai mentioned earlier about the importance of governance, architecture, program management with respect to digital health. So for the next 10 minutes, we will now look at a more technical level on how we can connect, we can make systems interoperable, because the things that were discussed earlier, it was governance, so it's very people-centric. And then we had enterprise architecture, it's very conceptual. And then we have program management, which is, again, it's people-centric. So now we look at the technical. So we have here a very interesting picture. So during the early 2012, 2010, 2011, 2012, there was a disease that was propagating in a country in Africa. It's actually in Uganda. So it's not COVID, it's not any medical disease, but rather we usually call this as next slide. We usually call this as pilotitis. This is a disease where there are so many pilots that are being done in an area. So if you can see here, in Uganda, there were implementations of OpenMRS, there were implementations from UNICEF, there were implementations from the WHO. So there were a lot of systems that were being deployed in the country. However, they were not able to use it in a proper manner. So why is that so? So pilotitis is not actually a problem of having so many pilots. It's okay to have many solutions. The issue encountered in Uganda before, and it is being encountered by countries right now. For example, in the Philippines, during the COVID-19 pandemic, we had 13 information systems that we need to use. And it was a problem for us because data was not flowing on those 13 information systems. So the problem with pilotitis is not having many pilots, but rather the pilots, the solutions, were not communicating with one another. So I think this was mentioned by Dr. Alvin in a very elaborate way earlier when he showed the graph showing digital health. So this is actually a problem of standard and interoperability. So systems are not communicating with one another. If we can put the solutions in one ecosystem, in a system where they will communicate with one another, then we will be able to maximize the benefits of those systems. So I think we have Paul Biandi later, and he will discuss how this can be how this will be integrated with one another using an architecture called OpenXIE. But for the next 5 to 10 minutes, we will focus on standards and interoperability. So in order for us to attain interoperability, I think Dr. Bunsai mentioned, it's important for us to have the standards. However, as mentioned earlier, using HL7 FIRE or using a standard is not the single solution. It's not the main solution. Okay, we have to understand that there are levels of interoperability. Not because we are using HL7 the standard, we will already attain full interoperability. We have to understand that there are levels that we have to look at. We have to ask ourselves, can the system communicate with one another? So I have a system here and another system here, and they send data to one another. That's the first one. Number 2, can the systems understand one another? I have data in the system. I sent it to the other system, and the other system understand that data. Number 3, can the systems work with one another? So can system B process the data that was sent to it? Okay, so that's the third one. So next slide. So for us to be able to make sure that the systems can communicate with one another, this is where the HL7 standards come in. HL7 standards like version 2 or CDA or HL7 FIRE, the main goal of those standards is to make sure that system 1 will be able to communicate with system 2. So they will be having the same format, the same data structure, the same data schema. That's the first one. Next slide. In order for systems to understand one another, this is where terminology like SNOMED, ICD-10, terminology services comes in. By having a common set of definitions, then the systems will be able to understand one another. So from the first level, from having communication interoperability, we now go to semantic interoperability. And then the third one, next slide, how can they work with one another? This is now where IHE or the WHO SMART guidelines come in. They standardize the workflow. So if we follow an IHE profile, then we will have a workflow in such a way that the data from system 1 will be useful, will be can be processed by system 2. So that is how we say interoperability works. So we don't want to focus on syntactic interoperability alone, but eventually the main goal should be we will have workflow interoperability. So as mentioned by Dr. Bunsai earlier, so during the past 5 years, the ADB together with AeHIN have supported standards and interoperability across the Asia Pacific region. One of the ways on how they supported it is by supporting the establishment of Interoperability Labs. So one of the first Interoperability Labs that was established is the Standards and Interoperability Lab Asia. So when the lab was established in 2017, the goal was for it to receive capacity building so that the same capacity will be distributed to other countries in the region. So when Kyla was established in 2017, there were other interoperability labs already. So we have the Mohawk Lab in Canada, which was the first interoperability lab in the world. And we have the Gembi Lab in South Africa, which was established in 2010. So they were already functioning. So when Kyla was established in 2017, we already had models that we can follow. Okay, but as we can see, there's some differences because while the Mohawk Lab was established to support North and South America, and while the Gembi Lab was established to support the whole of Africa, Kyla was in a different position because there were differences in Asian countries that are unique. Okay, and we will be seeing that in a little while. Okay, so what did Kyla do during the next 5 years? So number one, Kyla, we were able to deploy tools in our Kyla cloud. So what we did was we tried downloading tools and set them up so that other countries in the region can use these tools. Number two, we also supported the integration of PHIs2 and FHIR. So I think in COVID-19, many implementations of PHIs2 already had the FHIR component, but 3 years before that was not happening. So Kyla was able to convene experts from PHIs2 and FHIR, and we were able to develop some kind of interoperability between the two, between the FHIR standard and between PHIs2. We were also able to develop some knowledge material. So we were able to publish the experiences that we had at Kyla. We looked at how technologies will impact healthcare. So those are published works. We did some capacity building. So just before the pandemic came, we had one of the largest standalone HL7 training in the country. So we were able to bring in, I think, 70 participants from overseas. And we had our national fire workshop where we were able to invite around 150 attendees. We also have an internship program. So in 2019, we had people from the National Taipei University of Nursing, and they were with us for 6 weeks, and they have undergone an internship program with us on how they can set up an interoperability lab in their own country. And as mentioned earlier, the goal of Kyla is to help countries in the region to establish their own interoperability lab. So what is unique in Asia is because we have different languages, we have different realities. So it is virtually impossible for us to have a regional lab that will go in to each of the country. So what we feel is that rather than going into the different countries, we support them develop their own labs. So we were able to support Vietnam. We have worked with Taipei to set up their lab. Just recently, via World Bank funding, we were able to support Indonesia in a fire capacity building, and they are slowly building their lab also. Later on, Hill Island will showcase the work that they have been doing, and I think that's very amazing work. And then in the Philippines, just before the pandemic, we were already trying to set up the same local lab in the Philippines. So from Kyla, we were trying to establish now the in-country interoperability labs. So I think this is a very interesting line. So earlier, we showed that there were only 3 interoperability labs in the world when Kyla was established in 2013. So now, sorry, in 2017. Now, 5 years after, because of the support of ADB, of AeHIN, we were able to support over 13 countries regionally. So some of the countries, they were able to establish their own labs like Taipei, Thailand, Indonesia, Vietnam, even Nepal. Some of the countries, they are only at an earlier stage. So they are just setting up their Convergence Workshop, like as mentioned by Jai earlier, Laos. However, I think what's important now, and this will be the final message, from Thailand, the work now is downloaded to the countries. It is now the country's responsibilities to ensure that the laboratories that they have will be useful and they will be functioning so that they can support standardized interoperability in their own respective countries. With that, thank you very much. So we pass the floor to Paul Biandi, the main project director of OpenHIE.
Thank you, Professor Philip. But before Paul comes in, I'd just like to thank him for making time for us and also for agreeing for a partnership with AeHIN and OpenHIE. Dr. Paul?
Good evening from the Midwest of the United States, but good morning probably to most of you all. I'm really happy to have an opportunity to speak with you all. Thank you so much for inviting me. I don't have the fancy background that Alvin does, but I'll try to make up for it with good concepts and good ideas. So we heard a lot from you all, even in the previous presentations, about this issue of countries working with lots and lots of different kinds of health information that's being created, and increasingly health information systems that are being created to support that information gathering. And you're probably trying to figure out a way to start building an urban plan to integrate that information together, to use it in more meaningful ways. And I think as you started to hear from some of my other colleagues, it's just as much a people and process problem, this concept of architecture, as it is a technical problem. And so you might have heard of the concept of a community of practice, but you might not be aware that it's actually becoming a formal discipline that seeks to really help people understand how to work together in an optimal way. And it's formed by people who have a shared interest around something. That's really an important part of a community of practice. And in my experience, it's been a very low cost and a high impact way of scaling concepts and scaling impact across an enterprise. And within the OpenHIE community that I'm about to talk with you about, our shared interest is in advancing health information exchange within emerging economies and emerging environments all throughout the world. So in some ways, our focus is that we're looking collectively to walk together. So the OpenHIE community has come together and is comprised of hundreds of individuals and many organizations who collectively buy into this concept of improving health equity through open, collaborative, large-scale support of health information sharing and health information sharing architectures. So what does the community actually do? Well, it does a lot of things. You heard Alvin describe to you the OpenHIE architecture, and so some of the elements of the community focus around standard setting, both leveraging pre-existing standards, but more importantly, trying to fit those standards into real world environments. And more importantly, beginning to try to understand the ways in which these standards need to be modified and improved based upon the experiences that you all as countries are experiencing. In addition, there's a lot of work that we have to do in support of building the capacities of countries at all different levels, and we're going to talk about that here in a second. Some countries are moving beyond the concept of the urban plan, past the concept of the strategy, and they're actually moving into implementation. So a growing part of our community is really focused around implementation support. And then, of course, a lot of what we do is build relationships with each other. The concept of an architecture within a country is not something that you do overnight. It's actually something that takes years to work through. And the way in which we found that we've best succeeded at that, the countries that have best succeeded that have built relationships with each other, long-lived relationships that can persist beyond political changes within a country. So there are a number of different products. And one set of products is around standard setting. We have something that's called an architecture review board, and within that architecture review board, we've created an architecture diagram, which I think Alvin showed an earlier version of. We also produce an architecture specification. We've inside that have a whole concept of an architecture maturity model. We have a number of summits where we bring together people from all over the world to leverage pre-existing base standards to debate the ways in which those standards are or aren't useful within the kinds of environments we're looking to serve. And then we make modifications, community modifications to those what we call architecture specifications. In addition, we're starting to build a testing and conformance strategy so that as you all start to try to leverage these standards, there are ways in which you can validate them against a testing strategy. So you saw from Alvin an earlier version of this, but the thing that most people think about when they think about OpenHIE is this concept of an architecture which has at the top shared services, which uniquely define the different parts of metadata or the data that describes data. And then at the bottom, you can see a number of point of service systems like medical records or laboratory or pharmacy systems or supply chain management systems. But all of those systems are gathering information about individuals and populations. And so that interoperability layer, that green thing that you see in the middle, that's a conceptual concept of of being able to receive messages from all of these various systems and to receive them through this train conductor, this interoperability layer, which then helps to standardize those informations up towards the top. So there are a number of other community products. So I talked a lot about the focus around implementation. So as countries are moving from the concept of an architecture to the practice of an architecture, we have a number of groups that get together through what we call our implementers network, where we showcase our work in progress. We're working to develop impact stories where you can hear about other countries and the work that they've done. And we've also started to interestingly establish these practice areas. A lot of times, countries aren't thinking about necessarily building out a facility registry, but they're thinking about how an architecture can support universal health coverage or can support supply chain management. And so we have these practice areas which really are more focused around the use of an enterprise architecture and the ways in which people, process, and technology can support those. We also have, as I mentioned just briefly there and previously, a number of working groups around the different components of the architecture, everything from facility management to client identification to terminology management to patient level record keeping. You can see that there are these areas where you can go and basically learn about how to implement and to maintain both facility data at a country or regional level and also the technology that supports that, like a facility registry. We also have a secretariat, which basically supports a lot of the infrastructure that helps to basically grease the wheels, so to speak, of this whole community infrastructure. And I've noticed that a slide is not in the deck, but I wanted to also point out how there is an academy, an OpenHIE Academy, which is very focused around helping develop the capacity of all different kinds of cadres of workers within a country. And there are a number of online courses that come at no cost that will help you understand some of the foundations of interoperability and standards, and also start to get into a little bit of the people and process challenges. And we've also recently opened a certification course, which we're excited to partner with AeHIN and other organizations around to help really lock in and certify that some of these concepts around interoperability, and more importantly, the application of interoperability, are available within your respective countries. OpenHIE is made up of a lot of different organizations. And if you don't see your organization here and you're interested in engaging with us, you're very welcome. I do want to make a special shout out to our team at AeHIN, which we've been really proud collaborators with for many, many years now on multiple different levels. And as AeHIN is starting to note countries move more into a practical implementation phase, we're looking to deepen our partnership with AeHIN on a number of fronts, both on the capacity development side and also on implementation sharing. Because as AeHIN sponsored countries start to try to implement these record keeping standards, we suspect that you're going to come up with some hard kind of lessons in terms of what worked from our specifications and what didn't work. And we're looking to collaborate with you and learn in solidarity alongside you. I'm also really happy to say that we are steered by the very eHealth leaders that we're looking to support. And you might notice one or two of those eHealth leaders are friends to the Southeast Asian region. And in many ways, I am the project lead. I'm the person who's trying to oversee the operations of the community, but these people are my boss. Their goals are to steer the direction and the agenda of the larger community. And they're oftentimes sharing that feedback with us through their direct experiences working alongside countries. I think the really important point to get across to you all is that you can't just download a collection of specifications and create magic for a country's architecture. The process of building an architecture is about people and process, and the way that we get there is through peer learning. And we don't believe or I don't believe as someone here from the United States that I have all of the answers. In fact, I know very little about Southeast Asian culture. I feel very welcome I feel very appreciated when I come to your country, but there's a lot of knowledge and experience that you all have to bring to this conversation of architecture. Because of the people and process issues, we need to work in solidarity with each other. And so the way in which OpenHIE is going to be successful is if we can all work together, look at each other as equals, and try to crack this nut of building architectures together. So we really work hard to support reciprocal learning. We try to support peer support at all different levels, and we're doing better and better at this. We're looking to create forums within OpenHIE where eHealth leaders can support each other, and all the way down to tech vendors. So we're seeing lots and lots of groups that are building things like a client registry, or a master person index is another name for it. And so we're also looking to build peer support amongst those technologists. We're looking to see that the architecture specifications are much more strongly influenced through country examples. And so there's this give and take between the standards that are published by groups like HL7 and then the experiences that people have actually implementing them. And we believe that there's a reciprocal process there. And we're looking to deeply strengthen our partnerships. I don't mention AeHIN because I think our partnership is fairly solid, but we're looking to strengthen it within the South America region, within the European region, and we have what is a pretty strong and growing relationship with ONC here in the United States. So I just want to maybe just reiterate that you might have been expecting a deeply technical conversation, because people often say, well, where do I download OpenHIE? And you can download OpenHIE by engaging with the people and being a part of the community. We believe that at the end of the day, that's what this is all about. We are very technical people, but we also understand that if you give short shrift to the people and process issues, you won't get very far. And I feel like in some ways, many of you are starting to experience this firsthand, but we're really excited to engage with you all in a more deliberate way in the months and years to come. There was a lot more that I could say. In fact, there was probably a couple of hours of things that I would have liked to have said to you. So what I did is prepared a larger deck for you all. And if you click, or if you scan this barcode, or if you click that link, I'll put it in the chat for you all, you will see all of these slides plus many more. You'll see many more screenshots of various things like the Academy, like our specification, and you'll see a lot more details about some of the partnerships that the OpenHIE community is looking to grow. So I am interested in making some time to answer any questions in the chat or over voice, but here is a slide deck for you all to look into. I'm gonna pause. Thanks for the time.
Thank you, Dr. Paul. I know it's late over there, so I think we should field our questions to you before I show this slide. I did mention before that we would like to inquire about the OpenHIE Academy. I know you've mentioned it briefly, but could you tell us more about what's inside the Academy and what is your vision for the Academy? Over.
Sure. So I'm gonna, while I'm talking to you, I'm gonna type this link in. So if any people are interested, you can literally go look at it live. And so it's academy.ohio.org. And when you go to that, you're going to see a website with a collection of free online courses. And you can actually start taking tracks. And there is a fundamentals of information sharing and enterprise architecture that we're hosting. It's 4 courses. You can go take those for free. We've had well over 100 people go through these courses, and we're seeing a rapid growth in the amount of people taking these courses from all over the world. And you can go a step further and take a certification course. I've taken the course. Luckily, I passed. It was actually a decent test.
Congratulations.
Thank you. Thank you. I'm excited to have passed, but you'll see a number of other courses there as well. And we're looking to partner with AeHIN. There might be some subject matter areas that maybe aren't necessarily reflected that are really important to the AeHIN audience. And so we can maybe collaborate to build some content together, but we release it all as open content, public goods that are available to everyone. And we charge a very small, modest amount for the certification course, purely because we want it to be a real process for people and not something that they just quickly go through. and we take 100% of the proceeds and put it right back into the certification process and to the development of other courses. And so all of it really is developed as a public good because we're all volunteers.
Thank you, Paul. You did mention about digital public goods at OpenHIE would be one of them. There are questions regarding AeHIN membership, but I also like to ask, what about OpenHIE membership? I think there are some people interested in the audience.
Yeah, well, OpenHIE is a community. And what's really interesting is that there are people like me that would wake up wearing an OpenHIE t-shirt because I'm obviously deeply committed to it on a day-to-day basis. But then there are some that, they're interested in it, but they might not necessarily have a ton of time to contribute to it, but they want to follow along and maybe contribute around a certain subject matter. And so because there are people from all different walks of life, we think they're all important contributors. And so you become a member of OpenHIE simply by engaging. And there are ways in which when you go on to the website, the ohi.org website, you can sign up. And by signing up, we consider you a community member. And you become more of a community member by engaging. And when you engage with us, it's called a meritocracy. You gain influence over the community, and you gain the ability to help start making decisions. And so all I would say to you is that it's open for you. Everyone is welcome, no matter what your background and what your level of interest is. But we will take you because everyone is needed to help make these exchange activities work. And one of the challenges that we have, unfortunately, is that we all can't be on the same time zone. And so many of us oftentimes are 12 hours away. And so part of the fundamental reason why we're so excited about our partnership with AeHIN is that they can be a local community, a regional community that really is an extension of OpenHIE. And so in many ways, AeHIN is already serving as a part of the OpenHIE community. But we think that in order for us to all learn from each other, we need to build bridges between the various time zones. And so OpenHIE is by its very nature international.
Thank you, Paul. Please stay there. I'd like to we have some time for Q&A before before we take our break before part 2. So I'd like to address some of the key questions in the Q&A, and some of them also relate to AeHIN and OpenHIE. For example, Professor Lutfan from Indonesia asked about the OpenHIE framework and asked about the roles and responsibilities in the Philippines for what the ministries took on. And I shared with him that we use the OpenHIE framework to identify what are the important components of an interoperable national health information system: the client registry, the provider registry, the facility registry, and the terminology services. And in the governing steering committee and technical working group, we discussed who are the most appropriate members of the technical working group who would take ownership of those specific components of the OpenHIE framework, and then we got volunteers. So I think that's a good way to apply a very simple way to apply the OpenHIE framework. Just show it to the stakeholders and ask them, okay, who takes charge of this? And please make sure you have a budget for it next year, and let's come together regularly to find out how we can start, because they need to connect to each other. So they need to be regularly meeting and make sure that they're able to pass messages to each other. So in the Philippines, the client registry is PhilHealth, because PhilHealth has the largest database of all Filipinos in the country. It is larger than the driver's license. It is larger than the birth certificate system we discovered. And it is larger than the Professional Regulatory Commission. So PhilHealth was very much willing to be the client registry. Provider registry was also PhilHealth, because all the providers wanted to sign up with PhilHealth. It was very easy to convince them to sign up, because that's the only way they could get their reimbursements. The facility registry were under the Department of Health, because everyone needed to get a license first at the Department of Health before they could be a accredited facility at PhilHealth. So just looking at the ecosystem, matching it against the OpenHIE framework, it really helped the steering committee and the technical working group understand, who takes responsibilities for which part of the interoperability framework. And then Dr. Fazila, you wanted to add something to that? You mentioned about your own distribution, your shared responsibilities with other.
Yes, and Yalvin, so we actually have to work with other agencies. It's not only within Ministry of Health. There are many other agencies and ministries that are involved in ICT. So when there is a project that cuts across, so these representatives of the agencies are in our governance structure also. So I think definitely we have to have shared responsibilities with others. I mean, Ministry of Health cannot do this alone. Yes, Alvin.
Thank you. And then there was a question on security. There are groups on security, so I do want to point you out to them. And then there was a question on whether the video of the session will be broadcasted. So we would like to defer that to the organizers, the Prince Mahidol Awards Conference, to respond to that question. Maybe we can show the slide, the final slide, Paul. We wanted to show you the final slide as well, Lukwa, on our invitation. So you heard about our GAPS framework, governance, architecture, people and program management, and standards and interoperability. And this is the framework that we have been following for the past 5 years since we hold and facilitate convergence workshops where we support the ministries of health. They are the leaders, they're the conveners of a convergence workshop. And this is where all the partners and sectors converge behind the leadership of the Ministry of Health. So you would invite the Ministry of ICT, the Ministry of Finance, the Health Insurance Organization, the Ministry of Education. This is where you invite the development partners, ADB, USAID, WHO. This is where you invite local companies, private sector. And in this workshop, we go through the governance, architecture, program management, and standards. We don't finish everything, actually, but it's a good start because it brings all of the stakeholders together and they all agree, okay, if this is what we're going to do, and we have seen this with our own eyes. Everyone is just so happy that they were called to the meeting and that they can now see themselves in the larger scheme of things. When they now understand, okay, so this is the plan and this is my role in the plan and I'm taking responsibility for this part of the plan. I will spend my own money. I have money anyway. Or if I don't have enough money, I'd like to ask for help and get some bridge funds. So it helps transparency and collaboration and planning, which we have realized in AeHIN is a very, very important thing. If we don't talk about what we're doing, I don't think it is possible for connect or transfer data between our systems because there was not even a platform for communication. So we'd like to invite this audience now at 2 levels. I mentioned this already at the OpenHIE conference last year, Paul, that this convergence workshop, we've been doing this for countries at the national level. We've done it twice in Myanmar, twice in Bhutan, in Indonesia, Vietnam, in Timor-Leste. The level, within the UN agencies, the health sector represented by WHO, the ICT sector represented by ITU. And if we can do this at the global level, I think that makes for a very powerful message to all the other countries that, we are already converging at the global level. So it could be a model for approach also at the national level. And we can help with that. We have experiences, we know the pain points, what to avoid, we know what to emphasize on. So I think this is something that we all can do for at least 2022. We've programmed at least one convergence workshop for the Convergence Workshop. But for Paul, because he's at the global level, I'd like to also offer that opportunity that we also do this, and OpenHIE playing a big part in the architecture part of the GAPS.
Dr. Alvin, can you hear me?
Yes.
There is a question from our friends from Myanmar, Sani Ling Kao. Sorry if I pronounce wrong. I will read the question for you. May I ask one more practical question? In Myanmar, we cannot use fingerprint to identify people in the rural area. It is very unrealistic. And in rural area, we try given out smart cards, but since the education level is still low, they lost it and simply forgot to bring that card every time. Retinal scan is expensive and very hard to scan up. I see iPhone like a dot projection authentication can be a solution. Can someone give me the direction? Any, comments or answer this question from the panel?
Paul, you might have more exposure at the global level.
I don't know a whole lot about the circumstance within Myanmar, but from my perspective, the whole reason that you do biometrics is to add discrimination to someone's demographic or biographic information. And so generally speaking, I've seen the most success when you minimize the amount of technology that you use to uniquely identify a person. So oftentimes a person has enough demographic information that can be used to identify someone, and then you use statistical matching through something like a client registry as a more effective way of uniquely identifying someone. The good thing about biometric devices is it adds discrimination to an individual's record, but it comes at a huge maintenance cost, right? Like there's a huge cost to being able to scan someone's iris or take someone's fingerprint. And oftentimes people will start with that technology, not realizing that people in their names and in where they live and what their mother's name is, they oftentimes have ways to uniquely identify people that don't require technology and are probably a bigger bang for the buck. But I don't know, maybe in Myanmar that it's a bigger challenge. But generally speaking, starting with the technology, in my experience, has proven to be very difficult. I don't know if that's helpful or not.
Thanks, Paul. And I would like to point out the same things that Paul said, that the biometric is part of the identification. But now you can see the link between the civil registration, the effective civil registration in the country. In Thailand, we integrated the identification system using the fingerprint and the civil registration operation registry, and with those it's more easy than using the demographics. And but this can be huge because of creating the civil effective civil registration is a big task also. That what my response. And I think we, the time is up. Over to you, Piraya.
Thank you to our speakers. So that ends the first part of this morning session. So we will now take a 5-minute break, after which we will proceed with the second session on the interoperability in UHC.
Health information technologies are rapidly growing around the world. There are many hospital information systems and personal health information systems developed in both government and private sectors, which cannot be interoperable effectively due to the complexity of healthcare system and lack of information standards. However, the health information standards are not a solution of integrated health information systems. The solution is building the community of stakeholders to agree on the standard. SILT Island was established in order to facilitate the health information exchange in the country as well as across the region with regard to the international standards. Our team consists of highly passionate people from government, academic and private sectors on building the interoperable healthcare system. We provide a collaborative environment to design, develop, and test the interoperable systems as 4 T's core functions, including teaming, training, tooling, and testing. Teaming. We build the network of healthcare providers and health tech startups across the country to create an environment of collaboration between developers and users. And also we collaborate with international institutes to share experience and knowledge on digital health. Training. We strengthen the capacity of stakeholders through the interoperability training and workshops by partner with SIL Asia. Tooling. We set up the interoperability tools, especially the HL7 FHIR, to enable all stakeholders to learn, evaluate and implement the applications that conform to the international standards. Testing. We provide a conformance testing platform that allows software vendors and healthcare facilities to test their applications against the international standards, and also certify their applications to ensure that for their applications can be interoperable with respect to the standards. For more information, please visit our website and feel free to contact us. We are looking forward to collaborating with you.
Welcome back to the second session. So from the Mind the Gaps framework, AeHIN members in governance and economy began doing practical work on interoperability, and they will be presenting the updates in this session. So this time, I would like to call on Dr. Alvin Marcello and Dr. Bunchai to talk to us about the AeHIN Regional Enterprise Architecture Council for Health, AeHIN, and Community of Interoperability Lab Accord. So please, Dr. Alvin and Dr. Bunchai.
Thank you, Piraya. So as Dr. Bunchai mentioned earlier, we have 2 groups in AeHIN. One of them is the Regional Enterprise Architecture Council for Health, and the second is the Community of Interoperability Labs. So we'd like to talk to you more about the Community of Interoperability Labs, which is the community of the countries that have created their own interoperability labs. So the story of the Community of Interoperability Labs started in August 2015, and this is where we identified the need to have identifiable people who will solve the problems of interoperability in each country. These people would be able to support the Ministry of Health for their interoperability needs. The interoperability need was already expressed way back in 2012. So AeHIN agreed, why don't we establish in-country interoperability labs where there is interest. And the Asia Development Bank, who was there, represented by Dr. Susan Roth, agreed to support the formation of an exemplar template interoperability lab because we didn't know where to start. So ADB was gracious enough to say, okay, we can support the first lab. And the first lab will be regional, and that first lab will then be the template for all the other labs to follow. So the Asia Development Bank signs a memorandum of understanding with the University of the Philippines, Manila. The agreement of AeHIN then was that the first standards in Interoperability Lab Asia was going to be set up the University of the Philippines, Manila. And it was set up at the Philippine General Hospital. So that's Dr. Bunchai. He flew over together with ADB at the back and our Vice Chancellor for the memorandum of understanding signed up. And then The Philippine General Hospital, which is under the University of the Philippines, Manila, put up an Interoperability Lab. And that is where we first set up together with Professor Philip Zuniga and other members of the lab, coming from their experiences when I visited Mohawk, and Professor Philip also interacted with the Mohawk people. And so during that launch, we had Dr. Eduardo Banson as well, and Dr. Jun Gao from WHO. Dr. Dodo Banzon is with the Asian Development Bank. We also had representatives from PhilHealth at the back, and we also had members from Pag-ibig, including the Philippine Health Insurance Corporation and the Standards and Interoperability Lab Asia, of course, the Philippine General Hospital. So in the March 2017 general meeting that we had in Naypyidaw, it was the first interoperability demo of the Standards and Interoperability Lab Asia in Myanmar. This was a response to the need of AeHIN to be educated and be made aware. How do we create the standards and interoperability? Who are the people that we need to put up? What equipment do they need? What software do they need to put up so that they can do this interoperability work? And so by the October 2018, in our 6th general meeting in Colombo, we then asked for volunteers from countries who would want to set up their interoperability labs within their countries, and we got sign-ups from Laos, Thailand, Philippines, Sri Lanka, Vietnam, and Bhutan. And together, these IOLs, or interoperability labs, form what we call now the AeHIN Community of Interoperability Labs, or COIL. They share knowledge, they share experts, they share experience, and together they will learn faster because they are now able to share their pain points and their solutions with each other. As we heard from Professor Philip's presentation, it's all about teaming, training, testing, and tooling. And those 4 T's are very technical work, but also collaborative work, coordination work. So the labs in each country, we hope, will mature up to the point where they can actually serve the needs of interoperability of their Ministry of Health and other stakeholders in their country. And so in summary, this is a slide that we already showed you. At the top, we have the AeHIN Working Council members. On the left are the enterprise architects of AeHIN. Some of them are actually inside the Ministries of Health. Some of them are our professors in enterprise architecture, our teachers. But we share knowledge, we share experiences with each other. Dr. Paul Biandi is actually a member of the Regional Enterprise Architecture Council for Health. So you can think of REACH as the group of architects who work on the blueprints. And you can think of the Community of Interoperability Labs as the builders of what is in the blueprint. So the blueprint that comes from the Regional Enterprise Architecture Council is of their specific country. So it will be different for Thailand, for Philippines, for Indonesia. And so we have started to get new members. Our newest member to COIL is New Zealand. On January 25, 6 p.m. Manila, they will talk about their interoperability lab. So we'd like to invite you there. I'll ask Charis to post the link in the chat box. They're the newest member, but I think also one of the more serious ones because they actually have a platform already set up. So I hope we can learn more about them this Tuesday. In Bhutan, it's just beginning. Mr. Garab Dorji, who underwent an enterprise architecture training, is also the team leader for the Bhutan Interoperability Lab. In Laos, we have Dr. Teputon Sorsavan. He's a member of the Ministry of Health, and he also completed the TOGAF training last year. So again, we are supporting the Ministry of Laos in their Standards and Interoperability Lab. For Vietnam, we have Pham Tan Dat. They are more advanced. They actually underwent training with ADB a few years ago, and they will put up the Vietnam Testing Center. So I think they will focus on the testing part of the Interoperability Lab. That, by the way, is also from the Ministry of Health. Then there's the Laboratorium Interoperabilitas Kesehatan Indonesia, or LIKI. I see Professor Anis in the picture, and Yudi. So I think the Indonesian lab is also at the beginning stages, and we will ask each of these laboratories to make an annual status update to the community so that we can learn from their experiences as well. Beside ADB, there is a Standards Interoperability Lab Center of Excellence in Smart Healthcare and High Precision Medicine. I think this is a group inside the ADB that's working on this. And in UP Manila, we have converting them to the level 2 operational material following the WHO SMART guidelines. So our team, I'm heading the technical part of the laboratory, but Dr. Janus Ong is a nationally renowned hepatologist working with the hepatitis surveillance program of the Ministry of Health. The idea here is to create the interfaces so that the electronic medical records around the country can submit hepatitis data securely to the Department of Health. In Sri Lanka, this is led by Dr. Roshan Hewa. And then finally, a recent addition to the interoperability community is the Open EMIS Community of Practice in Asia. AeHIN is the regional hub in Asia for the Open Insurance Management Information System. And together with academics and Ministry of Health members in the community of practice, we talk about how to do interoperability at the business layer, how the health financing and the health informatics and health insurance business processes come together. And that is manifested in the Open EMIS platform. So this is very new. And I know we have Dr. Julius Migrino, who is one of the members of the Open EMIS community, available in the call later on in the open forum if you have questions about Open EMIS community of practice in Asia. So these are the current focal points of Open EMIS. In the Philippines, we have San Beda College of Medicine, represented by Dr. Julius Migrino. In St. Luke's Medical Center, Dr. Sharma Ojeda. In Sri Lanka, Cambodia, and Nepal, we have members also in Open EMIS. So it becomes a platform as well for interoperability that we can, it's like an interoperability lab, but specific for a certain software called Open EMIS. And now I think this is the part where we talk about the specific work of the Standards and Interoperability Lab Thailand. We have a few more minutes, Dr. Bunchay, but I think this is a good time to give more time.
Okay, thank you, Dr. Alvin, to give the big picture of the COIN, the Community of Interoperability Lab, and also the relationship between the REACH, the architecture, and the standard. So from here, we will tell you about the activities that we work at the Interoperability Lab in Thailand. And from now, I would like to invite our technical lead, Dr. Papat Suriyapon, for the presentation of how the seal and right now the current that we do. Over to you, Dr. Papat.
Thank you very much, Dr. Bunchay. In the following session, we would like to share our experience and what we have done as Standard and Interoperability Lab Thailand. Our team, we are a team of people from government, academic, and private sector. Currently, there are 9 members in our core team. So the first session of the talk, I would like to introduce each member, so you know about them and their roles in SEAL. So the first member, I would like to talk about Dr. Bunchay. Apart from his role in AeHIN, he is also the clinical lead in SEAL. He is the father of TMT, Thai Medicine Terminology, that was structured like SNOMED City, and it has been used nationwide, and it really helped us a lot in interoperability of medication that we use in our project that Dr. Mr. Natanai will talk in the following session. He's now working at the Faculty of Medicine Ramatipati Hospital and also at the Thai Health Information Standard Development Center, or this. And the second member is Dr. Pia. He's from Faculty of Medicine, Chulalongkorn University. Actually, he wear many hats working at different organizations, such as China Medical Board, Thai National Health Foundation. He's also a member of National Reform Committee on Public Health. So he helped the team in policy strategic planning and grant seeking. So Dr. Pia is now our policy lead in our team. The third member is Dr. Dowler. He's our senior consultant. He's an excellent lecturer, and he's our team knowledge for SNOMED City and Lloyd, the laboratory code. He's now working at the Thai Health Information Standard Development Center, or this. And our next member is Dr. Govin. He's ophthalmologist at Bamrat Naradun Infectious Diseases Institute, Ministry of Public Health, but he's also very good at IT. He's the one who designed the dashboard in our pilot project, set up file server for our project and reach out for the Thai community. So you hear more about him in the following session. And our next member is Dr. Supaler. He's at the Department of Disease Control, Ministry of Public Health. He's actively working with the Ministry of Public Health in many areas, including COVID-19 right now. So having him in our team allow us to know the pain point and real need in our Thai health system. That's really good. Our sixth member is Dr. Rad. Dr. Rad, actually he used to work as a CTO at a private hospital and has a strong connection with health tech startup. And he helped us link with the private sector and health tech startup. Right now, he's working full-time at Thai Health Information Standard Development Center, or this. And he's really active and become a key person in SEAL team. Dr. Rad will share about our current 2022 project in the following session as well. And the seventh member is Dr. Thanapop. Dr. Thanapop from Khon Kaen University, Faculty of Medicine, Khon Kaen University. He has great experiences in mapping FHIR to the current data scheme, or vice versa. So he helps pushing knowledge from the academic sector. And today he will share also his work in mapping FHIR with the current scheme. And the next member is pharmacist Natanai. He's pharmacist at Faculty of Medicine, Sirat Hospital. He has been working with Dr. Bunchai on the Thai medicine terminology at the beginning, and he's a real implementer. I mean, he get his hand dirty in all SILK project. So today, pharmacist Natanai will share some of his first-hand experience on SILK in the following session as well. And I, as the ninth member, I work at the Faculty of Medicine, Sirat Hospital, Maidon University. Thanks to AeHIN, I mean, I was supported for TOGAF training and got certificate for TOGAF Enterprise Architect. So I'm member of REACH and also member of SILK here. My role in the team, I mean, Dr. Bunchai called it as a technical lead, but actually we are all equal in the meeting. This is like a brief history timeline for our SILK. We are about 3 to 4 years old. In 2019, Dr. Bunchai assembling the SILK team. He's the one who called all of us and built the team. So it start with the teaming, right? The 4T. So we start to learn about FHIR and all standard and try to build awareness. And then in 2020, we start to reach out to the community. Dr. Govin set up like group, set up Facebook, website, and our team start to create material and write in blog. We start to give a talk, give training, and we have opportunity to have the first pilot project that Dr. Nadanai will share it here. And then in last year, 2021, we have the second project that we hope that this will be the real implementation in a chain of hospital. And then we also have work from Dr. Thanapop that both Dr. Natanai and Dr. Thanapop will share in the later session. And then this year we have another two big projects that Dr. Lat will share about it. And then we also got the national license for Sinomet City. That's great news. So from here, I go quickly with some activity that we have done in each year. So in 2019, I try to go to the next slide. Okay, yep. Actually we give a talk in many places, but the real big talk at that time is in February 2019. We gave a talk at Health Tech Startup Thailand about the fire and try to build up community. And then in June 2019, we gave a talk at about interoperability and fire. And this event was organized by the Department of Medical Services, Ministry of Public Health. And in October 2019, at HIMSS Asia Pac 19, that's held in Bangkok, we have a session talking about interoperability and fire together with Graham Griff. And in this meeting, we kind of officially announced Silk Thailand to the public. And then in 2020, that's what I said, Dr. Kowin will start to build community, and then he will share in the following session. And then we had a chance to go to Philippines, Manila, to attend the AeHIN Regional Fire Community Workshop. And then later we gave a talk at the ICT Ministry of Public Health in April and in June about fire in big picture and fire in architect. And then we had one pilot project that Dr. Natanai, Mr. Natanai will talk about. Sorry, I think something, here, sorry. And then after the first project in 2021, we realized from the first project that when we implement the pilot project, one thing that raised our concern is that our work was specific to only one commercial hospital information system, or HIS. And I mean, if we finish this, it means that we just specifically create fire support for only one HIS. So we think, how can we, what about other HIS, and how can we create a system that is not specific to only one HIS and can be used throughout the country? So we are looking for something that require minimal work from the hospital and give them benefit as soon as possible. And then luckily, I mean, in Thailand, we have a common outpatient claim data scheme that used for reimbursement. So that nearly all HIS must be able to generate. So we pick up the one scheme, outpatient data scheme, that we call it CSOP format that Mr. Dutta and I will talk about later. So this is the one that triggered the idea for the second project that we are working on. And this is the one that Mr. Dutta and I will talk about in the following session. And then Dr. Thanapop will talk about his work as well, about modeling. That is his expert, right? And then this year, Dr. Rat will share with you about the two big projects that we got in for our team about the Thailand National Reform Plan, Big Rock 1 and Big Rock 6. I'm waiting for the slide. I will stop my talk on this slide. How come it's not? Moment, sorry. Yep, okay, sorry. So this, I stop my talk here, that this is the current capability of our SEAL team. we have members who are certified for COVID-5 Foundation, COVID-5 implementation, TOGAF 9, Nomad CT Terminology Services, certified HR7 Fire R4, certified HR7V version 3, HR7 version 2.7, and HR7 CDA. So thanks for AeHIN and support from many supporters who build up the capability for our SEAL. Now I would like to invite Dr. Gawin to share with us about SEAL and Thai fire community. Dr. Gawin, please.
Thank you, Dr. Prapat. Hi, everyone. I'm Gawin. I'm an ophthalmologist and a member of SEAL Thailand. I'll talk about our activities with the Thai fire community, what we've been doing after we met with Graham Griff at the HIMSS Asia Pacific Conference in 2019. First, in early 2020, we joined the Regional Fire Workshop by Standards and Interoperability Lab Asia at the ADB headquarters in Manila. We met several fire experts there and learned a lot from them. Then we came back to set up our parts. After that, we conducted several seminars with the Thai audience. For example, the group from the Department of Medical Services, Ministry of Public Health, and the group from the ICT Center of Ministry of Public Health. We recently had a session about HR7 fire at the annual conference of the Thai Medical Informatics Association last year. In addition, our members, Dr. Bunchai, Dr. Daurek, and Dr. Rat, have their lectures about interoperability in Mahidol University classes. Dr. Rat has his online course about fire as well. Furthermore, we've published the introductory articles in Thai language on our blog to help Thai audience quickly understand the fire basics. You can find the links to our blog, including our email address, on the SEAL Thailand website, seal-th.org. We've been also using social media to communicate our activities, interesting articles, and ideas to our followers. We've posted on our Facebook page and Line Messenger group. Both platforms are very popular social media in Thailand. Last but not least, we've built our own fire server, the public fire test server, based on the Happy Fire server. For those who would like to try the fire APIs and test their fire resources. In case you don't have or don't want to use your data, we've populated our server with more than 400,000 synthetic fire resources from Cynthia, which are ready to use. Currently, we have our complete and ongoing projects, and we are being involved in many health information exchange projects in Thailand. Let's move on to our projects. Okay, over to you, Sam Natanai.
Thank you, Dr. Gawin. And hi, everyone. In this session, we would like to share our experience on implementing the fire projects in Thailand. And for our first project is a model development for integrated HHE of DM and hypertension services in primary care. And in this project, we developed a prototype of integrated health information system for primary healthcare services that comply with the fire standard. For the conceptual model in this project, we use a trigger to capture the transaction data from the hospital information system and transform it into the fire resources and port these fire resources to the fire server that provide the standard fire API to connect with the third-party application. And in this project, we also identify the information needs based on the focus group with the primary healthcare providers from Kamphaeng Phet Hospital. And then we map the information to the fire resources such as the patient resource and other resource. So, and we post these file resource to our file server. And this is a web application that use the Fire API to integrate the data from our server, our file server. And what we learned from this project, we learned how to set up the Fire server. And this project, we found that the directly integrated SAS data with the Fire is very useful, but it's required to understand on the architecture of the hospital information system. And this is challenging for the scaling up with the other hospital information system. So for our next project is a permission-based blockchain for personal health record. In this project, we would like to encourage and empower hospital to manage their own secure file server. And we pilot at the Sirat Hospital Group, including the Sirat Hospital, SIPS Hospital, and Golden Jubilee Medical Center. And to avoid the business workflow interruptions and increase the scalability, so we decide to use the CSOP file that the public hospital have to export this file for the reimbursement for the outpatient. And we will transform this file to the file resource. And in this project, we firstly focus on the patient's medication information and try to implement the PHR with the smart contract by using the blockchain technology that's giving the patient to control the access permissions of their health data. For the conceptual model of this project, we use the CSOP file that hospital routinely export this file for reimbursement, and we convert it into the file resources by using the CSOP parser and post this file resource to the secure Happy file server. And we use a smart contract on the blockchain to ensure that only the authorized application and the person can access the data. And after finish this project, the artifact in this box, we will publish as open source. And this is this diagram show the data structure and the relationship between the us. So what is a CSOP? CSOP is a standard data model for medical reimbursement in the OPD service for the civil servant medical benefit scheme in Thailand. And there are three sets of the information, including the Bhutan, which is the information of billing claim transactions, and BUDIS is information of medication dispense, and OP services is information of the medical services and the procedures. And this is diagram show the data structure of the CSOP and the relationship between the Bhutan, BUDIS, and OP services. And as I mentioned earlier, that in our project, we are firstly focused on the patient medication information. So only data from the Bhutan and BUDIS are mapped to the file resources. And this is an example of mapping CSOP data element to the file resources. For example, the SN data element we map to the patient identifier. The invoice number we also map to the claim identifiers. And for the mapping with the file resources, for the Bhutan dataset, we use patient claim organization and location resource. And for the BUDIS dataset, we use encounter medication dispense and practitioner resource. And this diagram shows the relationship between the file resources that we convert from the CSOP dataset. For example, the claim, location, medication dispense, encounter, patient, practitioner, and organization that we convert from the CSOP. And also in this project, we also create a file profiles to define the constraint and the extensions that conform to the CSOP data model by using Forge. And we publish our profile on the simplifier.net, for example, the patient profile. And we assign the master port to the element that we derive from the CSOP data element, for example, the citizen ID, SN, and patient name. And this is a website that we publish our project on Simplifier. If you're interested, you can go to this link, the simplifier.net/CSOP. And what we learned from this project, firstly, in Thailand, the medication reimbursement are based on the dispensing information, but there are no directly relationship between the claim resource and medication dispense resource. So in this project, we use encounter resource and patient resource to link the information between the Butan dataset and the BUDIS dataset. And most of the identifiers system and code system in Thailand, they have no the official URI. So the same codes may be defined with the different system URI. For example, in our project, we define the hospital code with this system URI, but in another project, they use a different system URI. So it's difficult to integrate the information from different projects. So the national URI registry can improve the interoperability in Thailand by publishing the official URIs. So this could let every project use the same system URI in Thailand. And for the healthcare provider license numbers in Thailand are start with the Thai alphabet, such as the medical doctor, dentist, and pharmacist. However, the Happy Fire server still not support the Thai alphabet for the conditional update in the transaction and batch request, which is this is the method that we use to bundle our file resource and push it to the file server. So in this project, we decide to split and convert it the Thai alphabet into the identifier type, for example, the MD4 for the medical doctor. That is all my sharing. And now let me invite Dr. Thanapop to share his experience from the project of information modeling medical certificate. Over to you, Dr. Thanapop.
Thank you, Mr. Nadanai, and thank you, Dr. Prapat, for introducing me at the beginning. Hello, everyone. My name is Thanapop Nanakon Phanom. I work as a medical doctor and health informatician at Convergence University. For my part, I would like to share our experience in using HR75 for information modeling of the medical certificates in Thailand. Okay. So to begin with, I would like to talk about medical certificates. In Thailand, there are many kinds of medical certificates depending on the purpose of the certificates to be used. For example, the medical certificates for driving license is a certificate of medical examinations for applying for a driving license. A fit and well certificate is a certificate of general health examination. The signet medical certificates is a document that certifies the patient's medical conditions. And the proof of visit or admission certificates, these certificates may be requested by the patients and submit to their employer or insurance company for reimbursement. And the other medical certificates are more specific to the particular jobs and duties. Then this picture are examples of the medical certificates form in Thailand. On the left side, this is medical examination report for a driving license. And on the right side, this is a fit and well medical certificate. The document may contain the patient demographics, medical history, and the examination results. It is not a summary of visit, but rather just a document that essentially certifies that the patient was seen and examined by the doctor. And last year, the Ministry of Public Health and the Electronic Transaction Development Agency has been developing an electronic medical certificate, which is a digital and verifiable document. So currently, they are in the first phase of working on 3 types of medical certificates for driving license, fit and well certificates, and signet medical certificate. And this brings us to the work that our team have done. And in this project, the project aims to use the HL7 file for digital representation of medical certificates and interoperability. Our work was to model and define the file artifacts representing the content in the medical certificate. In the file data models, the most important parts are the resources. Resources are a collection of information that define data elements, constraints, and relationships for the business object most relevant to healthcare. Things of resource as paper forms, reflecting different types of clinical and administrative information that can be captured and shared. FHIR defines a series of different types of resources that can exchange and store data, including clinical data and administrative data. These are an example of FHIR resources. So in our work, we explore which FHIR resources and their data elements can be mapped onto the medical certificate content. And then we developed an information model for a medical certificate by specifying rules about how FHIR resources are used and their relationship with each other. And in the end, we publish an implementation guide that define a set of rules of how particular FHIR resource is used. In this project, 11 FHIR resources were utilized. As you can see here in this picture of implementation guide, Dr. Rad used the publisher tools to generate the implementation guide and publish it on the web. And this picture show an example of how we specify rules about which resource elements are used and are not used, with what additional elements are added, and rules about which terminology are used in the particular elements. In this project, we use Lois and Sonomet CT for the terminology system. In summary, we found that the HL7 FHIR can be used for developing an information model of the 3 medical certificates that I've already mentioned: medical certificate for driving license, fit and well certificate, and SIGNET medical certificate. And in the long run, we will extend our work to the other types of certificates as well. And that concludes my presentation. Next, I would like to move on to the next part, which is the mega project of our Sales Thailand this year. Dr. Rad will tell you more about Thailand national reform. Okay, hand over to Dr. Rad.
Thank you, Dr. Thanapop. Good morning, good afternoon, and good evening, everyone. I'm Dr. Rad Panjowat. I'm from I work for Thai Health Information Standard Development Center, and I'm also the member of SEAL Thailand. Today, I'm going to talk about the 2 national projects that we are at SEAL Thailand are involving. But before we begin, I have to lay the background first. So it started from 2014 coup d'etat by the National Council for Peace and Order, NCPO. After that, Thailand have gone through several reform initiatives, and eventually the National Reform Plan and Procedure Act, BE 2560, it was enacted and became effective from the 1st of August 2017. In this act, at Sector 8, it provided the action plans and procedure for the national reform shall be made on 8 issues. And one of them is public health. Since then, several projects was going on and many things happened. Eventually in 2021, the cabinet decided that we need to focus on the projects that can significantly change or improve people's life. These projects are called the Big Rock projects. And in the public health sector, there are 6 Big Rock projects. The one that we are involved is Big Rock 1 and Big Rock 6. I will begin with the Big Rock 1. The Big Rock 1 is dealing with the emerging disease. The primary goal is to prepare and respond to an emerging disease, such as the COVID-19. And in order to achieve that, we have to have a robust health information system, and health information exchange is the core component of that system, because we have to collaborate with many stakeholders and integrate all the data. And to achieve this HIE program, there are several sub-projects going on. I will give an example for 3 projects. The first one is the enrollment to become the SOMACT international member country. This is already have done a few weeks ago. The second one is Thailand will develop a file server, not the new file server. We modify the Heartbeat server for our purpose, and a tool to convert the claim data into file resource. Actually, this one is the same tool that developed at Sirirat Hospital that the pharmacist Natanai already mentioned about it. So after this tool is complete, the hospital in the country can implement this tool and build their innovations around it. The last one is the Government Big Data Institute, the GBDI. They will also develop the data repository for storing all of these data and use it for their purpose, for the analytics purpose. In this Big Rock 1 program, the one who is the manager of this program is Thailand Center of Excellence for Life Science, or TCELS. So waiting for the slide for a moment. Okay, so this is our first year plan at SIL Thailand. On the left side is the hospital in the country, many hospitals in the country. Some hospital might already implemented the file server in their system nowadays. Some might haven't done it yet. But anyway, both type of hospital, they have to have the CSOP data or the outpatient claim data produced nowadays, because they have to submit it to the existing claim processor for the reimbursement purpose. This is one is that Mr. Datanai already talked about. We will not change the existing process. It will continue go on. But what we will do is we will develop a tool that can convert the CSOP data into file resource, and we will encourage the hospital that already have a file server in their system to produce the same file resource, and we will submit this resource to the central repository, and maybe we incorporate other file data as well into the same repository, and we will go through the ETL process and then to the health management information system for the policymaker or other people to use the data. And after the first year, we will encourage all the hospitals in the network to have their own file server in their control, and we will incorporate the SOMACT into all of the information that exchange in all the network, so that all information share the same meaning between systems. And we will expand our support, not just the OPD data, but we will include the IPD data and other data as well into the file server. And because the hospital, they can control this file server so that they can use it for their purpose. Maybe they want to develop an application, or maybe they want to do some innovation about it. So this is the inside the hospital. But outside the hospital, they still have to send the data to the central repository, other hospital as well, and other system as well. But the data here will be much more comprehensive than in the first year. So then we can use this for many other purposes, and we can exchange it with other system as well, other network as well that share the same standard. So this is our plan that we want to do in the next 2nd to 5th year. I mentioned earlier that Thailand has become the member of SNOMED-CT International, but actually this have story for a long time because Thai Health Information Standard Development Center by Dr. Bunchai, Dr. Daurek, and many people, many team around here. They have been studying the potential use of SNOMED-CT since 10 years ago. And the Thai medicine terminology that this has developed is also inspired from the information model of SNOMED-CT and Australian medicine terminology, or AMT, which is the SNOMED-CT extension. Moreover, several provider and vendor in Thailand here, they already use SNOMED-CT for many years with the affiliate license. It's like they purchasing the license with their individual for use in their organization, not the country. They have done this for many years. So because we have the Big Rock 1 program now, so it's a good opportunity to push forward the initiative to use SNOMED-CT in the national level. So eventually, T-Cells allocate the Big Rock 1 budget to the Health Systems Research Institute, HSRI, to apply for the SNOMED-CT membership. And we became the 42nd member country of SNOMED International on January 12th. That's basically 2 weeks ago. And we are in the process of establishing the National Relay Center within THIS, this one. Next step for SNOMED-CT in Thailand, after we have the Relay Center, is that we plan to establish a national terminology server for providing the service to stakeholder, provider vendors, because using SNOMED without terminology server is quite challenging. So if we have this, it might be facilitate the implementation. And we will migrate the current TMT to be the SNOMED-CT extension, same as the AMT, that is the SNOMED extension as well. And we will develop a Thai extension. The first one is we think we will develop for the primary care system. And after that, we may expand to other areas as well. We will facilitate the implementation of SNOMED-CT in various projects. For example, the rheumatology registry, and we will provide educational support for provider and vendor. So that is the Big Rock 1. The next one is Big Rock 6. In the Big Rock 6, it's mainly about the National Digital Health Platform. I have to wait for the slide for a moment. Okay. It's creating a prototype for the NDHP, National Digital Health Platform, to use in other projects under the same Big Rock. Because in the Big Rock, they have many projects inside it, but they plan to create a prototype of the national platform that other projects can use to communicate and use this as an infrastructure. And if this go well in the future, NDHP will be a platform with many components, many services, many repositories to exchange health information between most public hospitals under the MOPH, and they will use FHIR as the main exchange standard of the platform. This is the presentation from Dr. Anand Kanoksin. He is the Director of Information and Communication Technology, MOPH. As you can see that in the health system, there is many components, but they plan to use the NDHP as the central component for exchanging of the information, and they will use FHIR as the exchange standard. And we are also studying the Open HAE that Dr. Paul already talked about in the morning session, that we think it's a very good framework for doing this. So we are studying it, and maybe we can use it in our project as well. And here is our SEALS Thailand's role in the Big Rock 6. We have 3 roles. The first one is where we are researching the digital health governance structure and mechanisms from various sources. Then we will propose a suitable model for Thailand, because right now the digital health governance here is quite a bit messy and complicated. So we have to find a way that's suitable for our country. And the second is we are developing the Thai National Fire Implementation Guide. Maybe we call it the TH Core, as in the US, they call it US Core. Maybe we have some quite similar things. And the last one is we are researching various appropriate information standards to implement in the platform, because the platform has many components and each component may require different standards. So we will find which standard suitable for which component. So that is our work in the Big Rock 6. So that is conclude my talk about Big Rock 1 and Big Rock 6. One last thing I want to mention is that we are open for international collaboration and domestic collaboration as well. So if any of the participants in this webinar have interesting idea or want to collaborate in any area, feel free to reach out to us. We are more than welcome to discuss with you. So I think this is the conclusion of the presentation from our SEAL Thailand member. So over to you, Piraya. Thank you very much.
So thank you to all our speakers. It was a nice presentation. So right now we have reached a discussion part.
I have a question.
Yes, please, Dr. Alvin.
Yeah, I appreciate the effort to create the TH core. I think many countries will want to create their own cores, CORES. So I think it's a good activity we can do at AeHIN, like a common AeHIN core, and then each country will then extend that with their TH core, PH core. Just a suggestion. Over.
Sure. Alvin, because we part of the country and also we part of the regions, and this is our aim to work together. So because of we think about this, and we will be a kind of the pioneer, and then we need all the core member to jump in and help in the part of that. And to me, I think create a common core fire implementation guide is a very cost effective, like another standard, like the medication standard, Thai terminology standard. We are happy to share with the regions and also the experience. So this is why the network in regional level and in the country level have been prevailed to give the audience about the context of SEALs. SEAL is very informal. Everyone here are from many organizations, and we are come because of we passionate that we would like to do we like to build the integrated health information system for our country. That is, I think, the reason why people are taking time studying, implementing all of this. Sure, we should do the AeHIN course. Jai, I saw your raising hand. Okay.
Yes, Dr. Bunchai, I have a couple of one question and one comment. The comment is related to what you and Alvin had mentioned about the core data set. I think it's good to change.
And again, it relates to my question on if there is a minimum standard or a national standard for medical certificates. That's very helpful, because I know someone here in India is working on a disability project where the practitioners can actually use a mobile app to certify disability. So if there is a standard on that, and that can be shared by the countries in the region for reference, that will be good, because of course national standards are defined by the National Medical Council, but then if there is a repository at least to look up, that will be very helpful. My second question is related to because you're working, it's fantastic work done by you and your team in the Standards and Interoperability Lab, and congratulations for the journey so far and what you're planning to do next. My question is, like, is there a HL7 Thailand chapter and the national chapter, and do you have any collaborations, because it does require?
I think you have two questions about the standard of the minimal data set, or the data set for from each use case, and then it can be shared. The second one is that is Thailand have a HL7 chapter? Anyone from the panel, Dr. Papat, Dr. Rat, or anyone, what would you could you respond to these two comments and questions?
I can answer for the first question about the medication certificate, medical certificate one. Yeah, of course we can share with you, with the community. The slight problem is that even in Thailand, we still haven't officially published this yet. That is, it's still process of back and forth and collecting the feedback from many parties. I can share it with you, the current version one, but it might be changed in the future. Yeah, and not just in Thailand. Actually, during the process of creating them, me and Dr. Thanapov, we also review the medical certificate from an implementation guide from Germany. I'm not sure who created that, but we found it on the simplifier. So I can send it to you too.
I can add a little bit, Jai and the audience. You can see that the issue is not much technical. Once the people can interoperate and agree on something, it can be created. But right now in Thailand and in many countries, to me, like in Thailand, we still have many stakeholders, and there is no consensus on that. People would like to more prominent than the other. That's why the governance and convergence is the essential need in Thailand, and we hope that we can push this and then reveal to the stakeholder in the country that this is the time that we should come and work together. So it is people interoperability is the main challenge, and we produce the technical, the information model, but it seems like people are not using it or adopting it because of they maybe have some issue on that. For the second part, Dr. Papat or Dr. Kawin, could you answer about the HL7 chapter? What should we do and what should we proceed on that? Over.
Maybe Dr. Kawin can add later, or our member can add later. But I think similar to what Dr. Bunchai and Dr. Rat said, we still not kind of finalize or settle in-house. So I'm not so sure. I mean, thanks for Jai for suggesting. I'm not so sure whether it is the right time for us to have that chapter. I mean, we would like to have something a little bit. I mean, it doesn't have to be kind of final, but stabilize a little bit. So it is in the plan actually.
Thank you, Dr. Papat. Dr. Bunchai, if I may just add to what you said, I think people interoperability and having the national consensus, it's a tough part. It's the tough part. Technically, it's probably relatively easy to solve. You have the team in place. This is where, like, I also posted about the unified health interface. the synopsis. What is happening here in India is like the same thing. Like, India is also very huge, very diverse, and so many companies, so many hospitals, both public, private, and trust. But then what has happened in the last 1.5 years is the National Digital Health Mission and the National Health Authority, who is the lead agency for implementation of National Digital Health Mission, has actually started this public consultation process, where they actually, it's sort of similar to our Convergence Workshop, but then they actually meet with these different partners, have a very frank discussion, and then after the inputs are taken, they actually publish publicly. It's available as a public consultation document. That document is available for anyone to look at it, comment, draft critically. You can actually respond to that. So they give a time of for about few months or a month after the consultation paper is available in the official website of the National Health Authority. And then once the comments are in, and they finalize it, and that becomes the consensus nationally. So this is something that probably you could do. I'm sure that you might have done something on that, but I just thought I will share in this point of time, since because this is an issue that is there in every country. Thank you.
So right now, actually, I saw 2 attendees raising their hands. You can ask us now.
Okay, so let me first congratulate everyone. Like this is really interesting, and this is exactly what I'm looking for. And from what I've heard and what I just learned from Facebook, from via Facebook for SIL Thailand page, the world-class 5G smart hospital system with smart health tech, blockchain based personal health. Those are the things that I'm exactly looking for. So I'm really interested in it, and I'm really like to collaborate in the future as well. But I also would like to share some of the challenges that we face related to the first session, the first question that I asked around the end of the first session. So in Myanmar, the thing is that we have our ID card, but that ID card is just a piece of paper right now. And the biggest problem is that where we normally work in ethnic area, eastern border of Myanmar, like only maybe I can say in my project area, 40% of people have those ID cards. So we cannot create a unique identifier. So when we start a pilot with 10,000 population in 2018, it is not a big problem. We can still manage about the duplicate. We can manually clean the data. We still use low-tech resources to make sure that people have a unique ID and put it in a paper format so that we can record it. But right now, because of the success of the phase 1, we call it strategic purchasing project, we are expanding to in phase 1, we are only covering 4 clinics. We are expanding to 17 clinics right now. And we are facing a problem with those duplication of the unique ID number. That's why I was hoping to get a guidance on biometric, because we want to invest and we try a lot of different methods. But none of the methods that we try, like the fingerprint, the smart card that we try to give them, and even the retina scan, it is not possible. That's why biometric, I understand there is a kind of like a sometimes use those biometric data to actually make sure that people are not receiving care. But we are trying to implement an opposite system where we are reducing the burden on the health worker, but at the same time, I'm to actually reduce the data duplication as well. Because when you go into the field, if you don't have a proper proper system to uniquely identify each patient, it is very hard to track their health records. It's very hard to actually give quality care. So that's where I'm coming from, as like in Myanmar, we have a kind of like a blank system. If we can prove some of a worthy or some of the low cost, some solution that can be useful throughout Myanmar, from my pilot project, we can expand to the whole of Myanmar. That's my long-term ambition as well. So in that case, one of the biggest problem we are facing right now is the data duplication, because people, the patients themselves don't remember the codes. No matter how much we try several methods to uniquely identify them, but it's still a problem. So it would be a great it would be great if some of you can give us guidance on that. Thank you.
So, Mr. Zai, I saw you raise your hand, so you want to answer?
Yeah, thanks,
Mr.
Priya.
Zani?
Yes, Dr. Zani, like in India, like for example, the unique identifier, like probably you would have heard about Aadhaar, the unique identifier, the world's probably largest ID scheme, not health ID, it's a ID scheme. So it's like close to, I think, 1.2 billion people have been issued. And it's based on, but the biometrics is based on both fingerprints, all the 10 fingers, as well as of course, the thumbprint as well as the retinal scan. So it's a combination of both. People do have a problem, because I myself have faced this problem, especially who is in healthcare, who keeps scrubbing, right? We keep actually washing our hands very often, and then also the laborers, like who do a bit of hard work. Fingerprint recognition is a problem. And then of course, like in those cases, retinal scans are used. Yes, I understand from your previous comment that this scans or ID scan, for example, it's expensive, but then like that's what is followed here in India. But relating to maybe cost-effective scheme, if there are multiple IDs in the country, for example, India does have, like people have driver's license, people have the tax ID, people have voter ID card for election issued by the Election Commission. Then we have a public distribution system which gives you the ration card. So there are multiple IDs. So one of the ways, like for example, of uniquely identifying is if there are secondary identifiers linked to the particular patient, then yes. Like my suggestion is, like if you do not have a national ID or an ID which is not accepted all over the country, particularly, then you can take which is the most widely accepted one and try to link yet another ID as a secondary identifier. With this, like it's sort of a triangulation. I won't say triangulation, but something sort of as much as possible try to uniquely identify a patient. That's my suggestion. Thank you.
Thanks for your answer. Can I just add in a little bit more? A little bit more is that, like in the eastern border of rural area, in Myanmar, a rural area, they don't have the cars. They don't have workers ID. Most of them are farmers, agricultural workers. So in that case, they also don't pay taxes. So it is really hard for us to, and plus, as I said before, no national ID. It is really hard for us to actually rely on the previous system from previous sector to make sure the triangulation exists as well. So in that case, what we are hoping is that we could, since this is kind of like a blank state, a blank piece of paper, we could start a new system. And if it is successful and if it is easy, it could be transferred to other part of the country as well.
I can respond to this a little bit, that the lesson that Myanmar are facing has been facing in Africa, both West and East Africa, for many years, and we can learn from that. So that's what I heard. And the ATRA from India, a project from India. This is people say that it is the most successful project for the identification, and I think Jai can respond to that too.
So are there any more questions, or any panelists want to add more details here?
Freya?
Yes.
Maybe just very quickly, we haven't pegged the dates yet, but before we end the conference and the side meeting, just to announce that this year we will have our 8th general meeting sometime in the end of Q3, and then we will be opening up a call for participants to interoperability training on FHIR. And then we will also be conducting some follow-up research on our GAPS framework. Did I forget anything, Jai, Dr. Bunchai, for this year?
I think one question that posed in the Q&A is very interesting, and I would like Dr. Papat to respond to the wider audience. There is an anonymous attendee asked the question that for a doctor who has no background in health information exchange and standard and interoperability lab, what would I start to learn to understand more about them? Do you have any recommended course or resources for the beginner? Over to you.
I think we can post the resources, the real resources online, free and paid resources on the website later. But to work on HIE, I think there are many aspects or many sides. You don't have to be really technical. As a doctor, I think the person who asked this question, actually he is a medical doctor, so he can really help in just give the real requirement, the real scenario, and work on that side and test the scenario, make sure that it's really workable. So you doesn't have to be really technical part or IT people to work on HIE. I think it's a real community. We need from all sides. I mean, in any way you can really contribute to the community. You can really, or you can just get in and test it, whether it works for you, and you can give feedback. That really helps.
I think for the HIE, Health Information Exchange, as Paul Biandi said that there is the Open HIE Academy. I think that is maybe the good resources to start to understand the HIE, both the business part and the technical part. And also, I think there is several courses. Even in AeHIN, we provide several webinar on the
YouTube
on this topic. Both YouTube, something like that. So, Dr. Alvin, I saw Dr. Julius. Any comments and suggestions from Dr. Julius on about your projects? Over.
Dr. Julius, any suggestions on open emails? I don't know if you have the microphone on right now.
So thank you for inviting me to this conference. So I really learned a lot, and I'm actually very excited, especially in the local context here in the Philippines. So coming from an academic institution, I'm really looking forward to collaborating with actually non-medical practitioners, which I already told the I guess the newer members of AeHIN Open Imis last time we met. And I'm very excited to meet them. Looking at the interoperability and the enterprise architecture, these are terms that as medical doctors we're not really trained for, but looking at what the other countries are doing, we're really looking forward to implementing something like this also, at least as far as what we can do in the academic sector first, but hopefully it can translate into the general health system of the Philippines.
Thank you very much, Dr. Julius. Thank you. And I was announcing some of the activities for 2022, maybe as last minute fire training, and then the AeHIN GM and the update on our GAPS research. And with that, I think I'll pass to Dr. Bunchai for the final words.
Another resource that we are developing with the Open Imis is that we are going to doing the training, e-training course about the diagnostic related group. Diagnostic related group is the financing tools that you can see the link between the financing information system and the healthcare information system in the real world, because of these tools have been used for reimbursement in many countries, including Thailand. So AeHIN are working with the Open Imis community to create this course. So we hope that in the next 6 months we can have this course online. But during this 6 months, we will conduct a webinar on this topic. I would like to thank all the panel on providing your effort and your time to come with as a community to exchange knowledge and learning. And also thanks all the audience. And we are on the same challenge, and we will work together to overcome this challenge, and we are here to support each other. So don't be shy and don't be hesitate to working with your friends and our communities. And the last thank you is to the Pin Mahidol Award conference organizer that provide the opportunity for us to kind of come up and sharing our knowledge on this. Now over to you, Lukwa, to close this this session. Over.
So again, to all the attendants, so you can join us to be a member of AeHIN. So we have many useful webinars and training that can be good for you. And I just want to say that if you want to review this record again, so the PMAC organizer will post it on the PMAC website, so you can look at it again if you want. And at last, need to thank you to all our speakers. So right now is the end of this side meeting. It's 12 o'clock now. And thank you all the participants here. So maybe we may have a chance to meet again in other meetings. So everyone, so have a good day, a good night. Goodbye, everyone.